All right, good morning, everyone. Thank you for joining us for another edition of High Rounds. So I'm going to introduce our speaker today, Dr. Gabriel Wagner. Dr. Gabriel Wagner is an associate professor in the Division of ID and GPH at UCSD. He completed internal medicine residency training at the Cleveland Clinic and infectious disease fellowship at UCSD. His areas of interest include improving health disparities in HIV prevention and gender-affirming care, in addition to general infectious diseases in inpatient and outpatient consultation services. He provides HIV primary care, HIV PrEP care, and gender-affirming care at the UCSD Owen Clinic. Thank you very much, Dr. Wagner, for being here, and go ahead and take it away.
All right, thank you, Marvin. And you can hear me okay, and slides look good.
Yes.
All right, everyone. I have no disclosures. So today, going to talk about this is going to be the outline for today. Going to be talking about disparities in PrEP uptake. Going to be talking about why these disparities are observed, including social and structural determinants of health. And then we're going to be talking about some of the creative ways that researchers have come up with to circumvent and counteract some of these disparities. And then finally, I think like the second half pretty much of today's talk is going to be talking about some of the work that we have done with a pharmacy prep implementation study. Hmm. So to get started, we'll talk about these disparities in PrEP uptake. And I previously showed this slide, I believe, the last time I gave this talk. Several of the slides that we'll use today, I should say, were used in the previous talk, although I tried to update it as much as I could. But this slide in particular, this study in particular, I wanted to highlight again because it's so powerful. This is a study conducted by the CDC presented at CROI in 2022, showing the estimated lifetime risk of HIV diagnosis in the US among cisgender men. And they broke it up into different racial ethnic groups. And here they used the National HIV Surveillance data, the CDC, from 2017 to 2019, I believe. And just by way of background, the estimated lifetime risk overall total was one in, I believe, 1 in 120. So, but here you can see, and I hope you can see my cursor, that if you look at the risk in the white and Asian subgroups, then it's significantly lower. Whereas if you look at Black and Hispanic, then the risk is much, much higher, 1 in 27 and 1 in 50 among Hispanic. So, this is quite a disparity. And the authors go on to state that this is as a result of structural inequities that exist in healthcare and systemic racism that it works through this complex network, right, of policy, clinical practices, and systemic. This slide shows the estimated HIV incidence from 2010 to 2019, and many of us have seen these data before, but it goes on to show, something positive that has come out over the last decade or so, which is that the HIV incidence has decreased. This is looking from 2010 to 2019. This is again from the CDC. The overall HIV incidence decreased by 12%, which is excellent. However, when you break it up by racial ethnic groups, then we actually see that a lot of that is carried by the white subgroup. Whereas if you break it up into Black, African, Hispanic, Latino subgroups, then we actually see that the incidence rates in those groups during that same time period actually stayed the same, or maybe even got worse. And so, what a lot of us that work in this field already know is that the people that need it most are the ones that have access to HIV prevention the least. So this is CDC slide from 2021, data looking at estimated PrEP coverage in the US by race ethnicity. And here in the dotted line is the target goal based on the ending the HIV epidemic initiative. And this is as of 2021, the overall goal was overall coverage was 30%. And among the white subgroup, it was 78%. However, among Hispanic, Latino, it was 21%. And among Black African, it was only 11%. I tried to get updated data for this, but the CDC actually is not currently, it doesn't have any further updated data. The means of collection, the measurement for PrEP coverage, I think it's under revision. So I think that's more updated numbers will probably be coming soon. Okay, so why do we see these disparities? And Dr. Laron Nelson at Croy in 2023 gave an excellent talk about this. And so a lot of the stuff that I'm going to be covering covered in his talk. And a lot of this has to do with social and structural determinants, so unstable housing. And I should say these determinants have long been described. This is a CDC flyer from a meeting report in 2008, where already, these determinants were being delineated. And so, for example, having unstable housing can lead to poor HIV outcomes and poor respiratory health. We know that it's difficult to stay with a daily oral PrEP medication if you don't have a roof over your head. Unemployment, this can lead to decline in immune function, higher hospitalization risk for people that live with HIV. Incarceration history, can be associated with HIV infection. It can be associated with self-reported HIV risk and reintegration related substance abuse. In the US, it can be difficult to integrate back into society after being incarcerated. It can be difficult to find a job, and that can lead to less access, especially less access to employer-based insurance. Then there are individual and network level barriers. And so these are barriers that are working at the individual and at the network level. And these include lack of awareness about HIV and PrEP, especially having a discordance between the actual risk for HIV and the perceived risk for HIV. Concerns about side effects, especially if one isn't aware or perhaps is hearing about side effects from folks and authorities that are not reputable medical authorities. Competing priorities, if you have to worry more about the roof over your head and where you're going to eat, you're going to prioritize taking a daily medication less. Stigma is very important and it can have multiple dimensions. There can be HIV-related stigma, PrEP-related stigma, heterosexism, medical trust, and racism. And a lot of these a lot of these stigma related to different dimensions can intersect and make matters worse for access. And then social and sexual networks. And these and sexual networks can significantly impact awareness about PrEP, and it can modulate expectations around PrEP use or non-PrEP use. And then we talk about healthcare system level barriers, and these are barriers that act at the healthcare system. And these can include factors such as clinician-related factors such as bias, racism, sexism, and homotransphobia. A lot of us that work in urban academic health settings may be subjected to uh, we may be more culturally competent, but when we think about the diversity of healthcare settings in which people might seek these services, then the landscape becomes much more diverse. There can also be stigmatization of people with substance use disorders, and that it's uh, still a very prominent observance. There can be lack of PrEP knowledge, and as a result, or fear of sexual history taking, or the time that it would take to tackle these issues in a safe way, and therefore not addressing it at all, and concern about risk compensation. And then there's factors impacting prevention and care service delivery, and this includes screening or mis-screening for PrEP, or uh, not thinking that a certain patient demographic would be apt to screen for HIV, or a possible candidate for a PrEP for HIV or doxyPEP. Purview paradox. So, where is the most optimal healthcare setting to deliver PrEP? And mistrust of clinicians and health institutions. And this is based on previous negative experiences that patients and folks have had with clinicians and health institutions. And then there's structural level barriers, and these can be real and perceived. Financial barriers. There's the distance to PrEP providers, lack of transportation, so-called PrEP deserts, as has been called in the literature. Policy decisions, whether or not to expand Medicaid and jurisdictional PrEP assistance, immigration status and limited English proficiency, and medical and government distrust. So, what are some of the novel frameworks and interventions for PrEP delivery? And going back to Laurent Nelson's talk, it's one of the things is that it's important for everyone, researchers and stakeholders, to think outside the box and reframe uh, the research infrastructure for more equitable implementation of PrEP access. That fact that social and structural determinants are not static and they must be actively counteracted. There can be a lot of inertia in thinking that a lot of these barriers are, structural and there's little that can be done about them, when in reality, there is a lot that can be done about them. They are being kept in place because they are benefiting some and not others. And they can be targeted. There can be organizational practices and policies that contribute to inequities. There can be norms across institutions that reinforce inequities, and political and economic incentives. This is an example of this is like a thought experiment, I guess, an idea from Challenges in Canada, where it kind of serves to visualize. This illustration helps to visualize this integration of scientific innovation going along with business innovation and social innovation. So, for example, the scientific innovation, long-acting injectable PrEP, but the social innovation to go along with it. How best to make sure that access to long-acting injectable PrEP is equitable across subpopulations and groups, and the business innovation aspect, for the incentive for the product to be profitable, um, and that users, clients gain the benefit from it, and that business operators gain the benefit from it as well, so that everyone in the circle is benefiting. And this is a nice example of this is the HPTN 096. This is a study that aims to reduce some of the disparities in PrEP, especially among Black African American folks. And this is done in particular by integrating multiple biomedical interventions, but through the lens of health equity and reducing disparities. And here they're looking at intersectional stigma, peer support, and other ways of counteracting some of these policies and practices. And a good kind of example of this is the fact that long-acting injectable PrEP can definitely reduce the disparities. This is a subgroup analysis of HPTN-083 among Black MSM and transgender women. This was presented by Hyman Scott at CROI in 2023. And by the way, quick plug, Dr. Hyman Scott will be coming to present at ID rounds in a couple of weeks, and he's an excellent speaker. So for the folks that are here that are able to attend that, he's fantastic. But in this subgroup analysis, they found that HIV incidence was higher among Black MSM and transgender women than non-Black MSM and transgender women, and that the protective efficacy of long-acting CAB versus TDF-FTC remained high among Black MSM and transgender women, and that TDF-FTC adherence was lower among Black MSM and transgender women than non-Black MSM and transgender women, and that adherence to long-acting cabotegravir remained high among both groups. So the group that could benefit greatly from LACAB. So this shows that here's one group that could benefit greatly from LACAB because that option appeared to be more suitable. So, already it's becoming apparent that a long-acting PrEP can be a powerful HIV prevention tool, specifically to address racial disparities. Okay. I'm sorry, I haven't been able to look at the chat or anything like that. So please let me know if there's
You're all
questions.
good.
So thanks. So and this is uh, I took this from Dr. Kelly at CROI to the 2023. The slide nicely shows some novel models of care to support PrEP uptake and persistence. And these include mobile clinics. So mobile clinics can be particularly useful because they can meet clients where they're at. They are friendly to the key population, community engaged, and they can provide comprehensive sexual and reproductive health services. There is peer-supported PrEP delivery, and this can include the utilization of peer navigators and peer PrEP clubs that reduce stigma and prioritize social motivations. There can be pharmacy-led PrEP. Pharmacies can have extended hours and lower barrier access, and perhaps a more neutral and acceptable environment than a clinic or a hospital. And I'll talk more about pharmacy-led PrEP in the second part of the talk. And finally, mHealth and telemedicine, which can include mobile phone apps, video evaluations, home testing, and they can ensure privacy and personalized care. And a lot of what's interesting and exciting about the field right now is the integration of a lot of these things. Mobile clinics that include long-acting injection PrEP, peer-supported delivery that is mobile, mHealth and telemedicine that includes peer navigation. This integration and especially the cultural tailoring of a lot of these interventions that are being combined are being piloted and researched across multiple settings. And so it's a very exciting time for the field and what this can show. And I just wanted to hear, it would be impossible for me to talk about all of them. There's a lot of things going on, but I figured I'd just talk about a few key examples. There's a mobile PrEP clinic developed by the University of Miami. This is specifically designed to low barrier PrEP. They provide PEP STI and HIV care services across 5 highly impacted neighborhoods in Miami-Dade. And they provide assistance with transportation, HIV and STI testing, lab monitoring, and medication prescribing. And they do all this with patient-centered navigation and ongoing support by multilingual staff. And this already has been piloted, and they did in-depth interviews with clients and key informants and program staff. And some of the identified facilitators included the fact that this is no cost services, the fact that it was a convenient location, the fact that ride shares were covered by the program, the fact that there was patient navigation, and the fact that there was a community-centric approach to patient care. That it was emphasized in this study, that the importance of community familiarization before implementation, particularly for Black and African American communities. And this is a quote from one of the participants, users of the program in the study, quote, about this mobile thing, that's the way. I mean, you can't beat on the corner. They eliminate all the excuses that's holding people back. Here's another kind of interesting and novel example, and I mentioned this, I think, at my last high rounds talk, and now this was last year at last year's CROI. Uh, there was some follow-up data on it. This is a very interesting utilization of hair salons in Durban, South Africa, for contraception and PrEP. So hair salons are a place where women congregate regularly, and they can serve as a supportive environment. The focus can be on socializing and on wellness. And this group, Dr. Ingrid Bassett, I believe she's out of Harvard, had piloted this and showed that it worked. It was feasible, and basically, as you can see in the pictogram below, basically the stylist introduces the study, and then nurse facilitates the questionnaires, provides testing, offers contraception, PrEP, STI screening, and risk reduction counseling, and then a nurse dispenses PrEP and or contraception. The participant can renew, accept, or decline at later visits. And basically, this was kind of acceptability and feasibility study that they presented last year. And I'm sorry, they actually looked at persistence on the study, and they defined persistence as one additional visit within 6 months with continued use. And what they found was that 69% of individuals persisted on contraception and 42% of women persisted on PrEP, which is significantly higher than a lot of the other kind of more standard interventions that had been done in the area. So hair salons are a novel venue for family planning and HIV prevention services. Um, and here's another interesting kind of thought, the utilization of telenovela or soap opera for HIV prevention in among Latino folks. So this is a study that specifically looked at telenovelas or soap operas for HIV prevention in Latinas. So telenovelas are serial dramas chiefly characterized by tangled interpersonal situations and melodramatic or sentimental treatment. They can be a lot of fun. And they can serve as an innovative medium for health education through narratives that document cultural expressions and address sensitive issues related to social and situational vulnerabilities. So in this study, this is just like the development of the intervention was the study. And their objective was to develop a culturally tailored telenovela to promote HIV prevention behaviors among Latinas. And HIV prevention behaviors included condom use, HIV testing, and PrEP awareness, access, and use. And so this study was conducted in community organizations throughout South Florida. It included 44 Spanish-speaking Latinas, 18 to 35 years old, and sexually active with a man in the past 6 months who participated in the study and provided the input to develop the storylines that would ultimately form the telenovela intervention. And the final product was an HIV prevention telenovela that incorporated Latina's ideas and feedback and was produced as 4 10-minute filmed episodes. And this is going to be tested, I believe it's probably already being tested. And so we'll see what the outcome of this is. And actually, I recently reviewed a manuscript that utilized a very similar approach for folks living with HIV, not for HIV prevention, but the telenovela approach. And it's a manuscript under review, so I can't say too much, but it looked generally very good. So here's an example of culturally tailored M Health for Spanish-speaking MSM and transgender women. This study, this is Al Liu from San Francisco and his colleagues, um, which I believe also includes Hyman Scott. So here they integrated two different apps. So they have this PrEP app, which is an interactive bidirectional text messaging, which promotes personalized communication between PrEP users and providers, and Dot Diary, which is a mobile app that promotes self-management of PrEP and sexual health through integrated electronic pill taking and sexual activity diary. And you can see an example of the Dot Diary in on the right over there. And they conducted focus groups with English and Spanish-speaking transgender women and MSM in San Francisco and Miami to culturally tailor PrEP and the Dot Diary. And so they basically, and so I think they did it, they did it in English and Spanish, and they did the tailoring. And then they did this 1 month technical pilot, and it generally looked very good. The mean usability scores fell in the good to excellent range, with mean satisfaction scores 28.3 to 20.6 out of a possible max of 32. And use of both tools was high, indicating good feasibility. And here's an example of, the integration of kind of multiple components, mHealth, Dot Diary, and uh, cultural tailoring. I think I'm going to skip this slide and to leave enough time for the second half. And I'll just mention that in this field, we have a lot of locally led novel PrEP delivery studies. This is just, and we have many. I don't know. Couldn't capture them all in one slide, but it includes Extra Mile, the PI Dice Bamford Young, Nexus PI Laramie Smith, Open Heather Pines, eStep Keith Horvath, and Lotus Dr. Myers Pantel. Some of these may have already ended recruitment, and some of them may have just been funded and haven't yet begun recruitment, but all of them are couched in ways to address disparities in PrEP, utilizing, some of the interventions that we have discussed, including mobile PrEP clinics, mHealth, and peer peer the utilization of peers and social networks for further engagement of key populations. So to conclude this part of the talk, disparities in PrEP uptake are driven by structural and social determinants of health. And to reach the goals of the Ending the HIV Epidemic Initiative, this will require that governments, health departments, end users, and researchers and community partners collaborate and implement innovative programs and policies in collaboration and with integration of multiple components. And it's important to keep in mind that broader structural reforms that address underlying social, economic, and political determinants of health will be key, especially in today's climate. Okay, so I'm going to talk a little bit more now about a pharmacy prep implementation study that was funded. This is a CFAR EHE supplement award. And this, harken or to go to echo what was said previously about utilizing pharmacy prep in a novel mode of prep delivery. As many folks here know, in 2019, California passed Senate Bill 159, which authorized pharmacists to furnish PrEP without a physician prescription. So they can start it 30-day with a refill, so 60 days. And yet, it has not been taken up very much. And actually, we don't know just how much it has been taken up, and we don't know a lot about what's going on now. This is an article that was written in 2023, and at the time, it showed that only 11% of California pharmacists, this is a survey from the University of California, Berkeley School of Public Health, and they found that only 11% of California pharmacists had prescribed the medications, and only 72% had heard of this pharmacy prep Senate bill that California had passed. So a lot of folks had not even heard of it. And this is from the study. Uh, they found that pharmacists, they value their role in providing essential sexual and reproductive health services, but many face policy and organizational barriers to implementing them in practice. And so addressing these challenges will be necessary. So keeping this in mind, this is the title of this study is Identifying Capacity and Strategies for Community Pharmacy PrEP Implementation to End the HIV Epidemic in the US. And this is an implementation study to look at pharmacy-led PrEP delivery. And so by way of background, as was stated earlier, and many folks are aware of the fact that pharmacies don't quite hold the same position as clinics and hospitals, perhaps. They have a different accessibility model. They're ubiquitous in communities. They can have expanded hours and walk-in capabilities. And as a result, they have the potential to reach populations that are not currently engaged in HIV prevention. And so the the purpose of this study is to assess the landscape and to delineate key barriers and facilitators to pharmacy-based PrEP implementation. So this is a multi-site collaborative study with us here in San Diego and Johns Hopkins University in Baltimore. Of note, California passed this legislation, and when the study was being designed, Maryland was about to pass the legislation, but ultimately, Maryland did not pass the legislation. So actually, pharmacy prep, you cannot get it in Baltimore. So that particular component of it can be studied here in San Diego, but we're utilizing both data from both cities to further add to the to look at both environments and see how both environments are faring. The study is an inter-CFAR and inter-implementation science technical hub initiative. It utilizes the implementation science hubs of CFAR, especially CFAR in UAB in Alabama. They have done a lot of work in this space, and we utilized a lot of their work, the initiative so far. And the objective is also to build alliance between two EHE jurisdictions, that's Baltimore and San Diego, and to development implementation strategies to support pharmacy-based PrEP. And this is an overview of the project. The rationale, as I mentioned earlier, is to assess the current landscape of pharmacy PrEP capacity in Baltimore and San Diego. The objectives are to develop and identify implementation strategies. And basically, it's being carried out in three phases. Phase one is going to be contacting pharmacists and assessing capacity and understanding the current landscape. Phase two is going to be understanding patient client preferences. And phase three is going to be conducting joint discussions with pharmacists and providers to understand best strategies. And the final outcome is going to be a menu of strategies for future testing across jurisdiction. And so here are the methods. Aim one is looking at barriers and facilitators, and this is basically mixed methods, quantitative and qualitative. So the quantitative part is brief surveys, and this is calling pharmacists and asking them what are they doing right now. Aim one, the second part of aim one is in-depth interviews with key informants, and this includes pharmacists and PrEP providers, and asking them what are the key barriers to pharmacy PrEP. The second aim is actually looking at users, PrEP indicated people, and their choices, their preferred choices using online service, using discrete choice experiments, and asking them, what would they want pharmacy PrEP to look like? And then finally, the third aim implementation mapping is utilizing focus groups among pharmacists and PrEP providers and asking them what are the best strategies to support pharmacy PrEP. And so today I'm going to focus on aim one. This is the study team at Johns Hopkins and at UCSD, and I just want to highlight at Johns Hopkins, Chris Kemp is an experienced implementation researcher who devised the study, and Lipin Lukos is a pharmacist who is leading the study, does the main data analysis and the main manuscript preparations. And here at UCSD, Terrence Hendricks has been the main person that has helped with data collection, as well as Shania Sidhu, who is a second-year medical student. And unfortunately, they are no longer in the study team now because their studies had to be prioritized, but they were amazing. They have a lot of skill, and they helped significantly towards the collection of the data that I'm about to present. All right, so and this is was an accepted abstract to CROI this year. So from May to September of 2024, the study team contacted all registered community pharmacies within Baltimore and San Diego, and that's approximately 200 per city. We used pharmacy registries maintained by the states of Maryland and California as sampling frames, and we used this census approach as opposed to a sample of pharmacies to assess geographical access to pharmacy PrEP in each site. So study staff called each pharmacy and conducted several short questions related to their ability to initiate clients on PrEP. For this part, informed consent was waived since the questions did not collect identifiable information or ask pharmacy staff to offer perspectives or opinions. As you might imagine, calling 200 pharmacies and going through an informed consent for all 200 pharmacies just would not have been feasible, given that this is just a 1 or 2 year EHE supplement. And a subset of respondents were asked, randomly selected and asked to participate in a follow-up interview, which was the in-depth interviews of the second part of AIM 1. And so this is the sampling coverage rates, and you can see here the total pharmacies. So in total in the entire registries in both Baltimore and in San Diego, there were 421 pharmacies. And of those, 418 were contacted, just because I think three were closed. So our study team actually contacted 418 pharmacies, which is a fantastic 99% coverage rate. Of those, as you can see here, so 148 out of the 236 pharmacies at in Baltimore completed the survey, 63% completion rate. 108 pharmacies out of the 182 contacted in San Diego completed the survey. So overall completion rate was 61%. So a little bit more than half, which is still pretty good given the fact that this was essentially cold calling. And as far as pharmacy types, these were the vast majority of them were chain pharmacies, 96 and one whatever that is, the 116 in San Diego, and followed by community pharmacies. Okay, so as far as PrEP initiation services go, okay, so out of 234 pharmacies in San Diego and Baltimore with available data, most, 81%, could offer HIV-related counseling services. 58% had private space available for counseling. Very few could offer STI testing, 1.7%, or point of care testing for HIV, syphilis, hepatitis, or renal function test. And then out of 181 pharmacies in San Diego, where you could potentially start PrEP, 10 or 5.5% of pharmacies had initiated PrEP. The average was 4 clients per pharmacy. Some data was missing. Some pharmacies did not indicate how many clients they had served. And most had started prescribing PrEP between 2 months to 3.5 years prior to the questions being asked. And as far as key informant interviews, so these happened almost concurrently later in the year, September to November. These were in-depth, semi-structured interviews that were conducted with pharmacists and PrEP providers. As I said previously, pharmacists were sampled from AIM-11 and PrEP providers were invited to participate through referrals. Informed consent was obtained for this part, and these were conducted via Zoom interviews, and these were conducted to explore perceptions of pharmacy-initiated PrEP and contextual determinants of implementation success. And the data were analyzed using qualitative content analysis and the consolidated framework for implementation research. And what was found is that there was substantial enthusiasm for pharmacy-initiated PrEP. Respondents felt that the program would reduce stigma and foster closer patient relations. Some of the identified barriers that were found included lack of awareness, prescribing status, staffing shortages, and insufficient financial compensation. And respondents also highlighted some potential facilitators, and this included adequate training, advertisement to the pharmacy clients, and systems integration, especially with co-partnering laboratories or other clinics as essential for offering PrEP initiation. Respondents also emphasized the need for proper workflow and protocols. Reimbursement channels was also highlighted, and leadership support from the leadership in their perspective pharmacy organizations. And so to conclude, pharmacy-initiated PrEP may improve accessibility and patient relations, assisting in retention. Addressing gaps in understanding client preferences will be crucial to successful implementation. And this is just like kind of the first part of the implementation study, of the pharmacy prep implementation study. The next part, we're still completing a lot of the data analysis from AIM-1. What I presented here is kind of like the first pass. So we're still doing interview data analysis, and this is going to be developed into the CROI poster and the manuscript preparation. Online surveys have already started. A lot of my colleagues in the Owen Clinic may have already seen flyers for any PrEP user that wants to participate in the study, and completion of the focus groups, which are already scheduled. And the outcome of this will be the development of a menu of strategies that can be utilized for future testing across jurisdictions. And I haven't been able to see the chat, but I can see that there's some questions, I think.
Yes, I will read them. Gabe, that was such a comprehensive and um really informative overview of, novel ways to deliver PrEP. You wove in so much, so I really appreciate. I think we all really appreciate the background and then the, amazing work that you're doing. So question from Robert Dice. I love that you got to send faxes to pharmacies for a change. Did you send repeated and multiple times in the event there was no response?
Just a little snarky, but
Well,
I
but I think it's a good question about how frequently you did do it, right? I mean, what was the reach out? I mean, your response rate was very high. I'm blown away by that. What do you think was responsible for that?
Well, there was, yeah, so yes, we did. And in fact, I don't know if Terrence is in the audience, but yes, we had a protocol that we followed. And so, yes, if someone didn't pick up the first time, we insisted. And so, just to be clear, the contact rate different from the actual kind of brief survey completion rate, right? The fact that we reached someone, but they decided not to answer our questions. Uh, but yeah, in the end, yeah, we call, you know, Lippin and Sam at in Baltimore, and Terrence and Shania here called and called until someone picked up the phone and either answered the questions or said no.
Okay, I'm going to do one more in the chat and then I'll get to the people waiting on the with their hands up. This is from Julie Darnell, one of our new pharmacists at Owen, for those who don't know. For the pharmacies that were doing PrEP, did you gather info on if they were able to successfully bill for the services? That is a big barrier to pharmacy-based PrEP. Um, and yeah, wondering about the success there.
Yeah, thanks, Julia. No, I don't know if we did. If anything, that's going to be more teased out in the interviews, but I don't believe that was captured in the surveys.
Okay. Richard Garfield, you are up first. Oh, we can't hear you though.
No.
Yeah, we can hear you now.
Now.
Yeah, sorry about that. Yeah, nice presentation, Gabe. Thanks for the update and congratulations on your amazing response rates. That's impressive. Um, I know that you were limited on time, and so you probably didn't present all the data you have, but I'm interested in knowing a little bit more about the differences in the types of pharmacies that provided the responses. So one example is the 1.7% of pharmacies that offered STI testing. Like, I'm really curious what type of a pharmacy actually does that. And so that sort of relates to other responses that you receive from the pharmacists. Are there certain types of pharmacies that are more likely to be amenable to PrEP versus others? Because that kind of information would inform, future interventions. So I'm sure you're already thinking about that, but maybe you can just elaborate a little bit on that right now.
Yeah, that's a great question, Richard. No, we haven't looked at that directly, but we could. Yeah, because we captured the types and we captured what each one was able to do. Like I said, this is still the first pass of analysis, but yeah, absolutely. It would be very useful to know uh, the environment, that allowed some folks to be able to initiate PrEP versus others. It seems like some, despite limitations, did it, and some, despite resources, didn't. So this needs to be teased out further.
Anik.
Thank you, Gabriel. That was awesome. I had a very practical question just because I don't understand how the whole kind of financial thing works. One of the slides, I think it was one of the CROI abstracts, said that one of the limitations was lack of financial compensation. And I think maybe my question is related to Julie's, but are pharmacies expecting to be paid extra for seeing PrEP patients, or are they expected to just do it as part of their everyday work, and so for them it's just extra work?
That is a great question, Anik. And the honest answer is I don't know. These are some of the things that we hope to tease out in the interviews and in subsequent analyses, because my understanding is that, so definitely feel free, any pharmacists in the audience or any folks in the audience who would have know the answer to this, but my understanding is that no. My understanding is that there would be no extra compensation aside from the support that they would get from the organization. Like the organization would, already co-partners with a lab, and the organization already has the infrastructure for the pharmacist to dispense the PrEP. That they, but this is what, this is what is being looked at, is whether programs can be developed so that any kind of gaps perhaps can be bridged in compensation.
Thank you.
Alan, you're up.
I think this is a good segue to my comment. I wonder if the pharmacists are aware that there are programs and a huge push from the California Department of Public Health for PrEP to do PrEP initiation at pharmacies. So they have a whole program that is targeted to having pharmacists initiating and being able to sign up patients for immediate access, which will cover the drugs and some other things. So I think that kind of helps the issue of not making money, right? Not being able to build the meds, or not the financial part. So I think that would be something important to explore, is to see if the pharmacies are aware that these programs are available to them. And even if they can enroll the patient, there is self-enrollment options also, that the patient can self-enroll and then utilize the pharmacy. The pharmacy does have to be in network with PrEP app. So that would be another thing, is pharmacies need to be aware that they need to be in network in order to build those meds through PrEP app. But that covers, a lot of people that are in that group of disenfranchised people that have no insurance and all that stuff. So just wanted to put that out there.
Alan, I have a question for you then. Sorry,
Yeah.
Gabe. I I thought it was more complicated to become a PrEP app prescriber. I didn't know that you just could sort of say, I want to do this. But maybe I still thought there had to be some attachment to something. Can you explain that process?
Not with a pharmacy. Let's say if somebody just wants to get PrEP, they can self-register on PrEP app. There's a self-register website that they can do it for immediate access. It's limited on what they can get, right? But they could have access to med right away. They'll get their ID, they'll go to the pharmacy, the pharmacist will prescribe the medication and then just bill it. So it could be as simple as that, right? The pharmacist will still have the discretion of needing an HIV test and all that stuff. But again, with the PrEP app, immediate access, they'll be able to bill like a swab, oral swab, or all the stuff. There's a bunch of stuff that's covered under the immediate access. That will also go for PEP and PrEP.
Okay.
the pharmacies are able to enroll patients the same way that I enroll them. They don't have to be enrollment workers. So they've created a program to facilitate that process.
Thanks,
But I think most pharmacies are probably not aware. And as I think Julie put on the chat, most of the chain pharmacies are not willing to take the time to do any of that. It's going to be more the community pharmacies.
Yeah, I think
But the good thing is if the information is out there, the patient can self-register, right? If they can self-register, all they bring is they bring their insurance card to them and say, bill this. It reduces the issue on the financial side and who
yeah,
is paying for what.
yeah, I agree. I think a lot of pharmacies are unaware, and I don't know about leaving it up to the patient. If anything, this would be something hopefully that because these are folks that already, they may not be able to navigate things. And so if the pharmacy on their end could help,
Yeah,
be aware of this PrEP app program, then that would
the
be
potential that I see is for if we can connect the pharmacies with, let's say, LGBT Center, for instance, that does the testing, right? If they can connect the patient and say, okay, you get tested here, you go to this website, get an ID for PrEP app, and you go to a pharmacy and get a med. It will kind of be like a multi-organizational effort to get people in care, at least temporarily.
and of course, this is just California.
Correct.
I mean, of course, this is one step further, but I think a lot of pharmacies would obviously be an ideal place to do injections, as we as we are aware. So they would be fabulous sites for both cabotegravir and Len injections. Forgive me, Gabe, if this was asked in the surveys. I think you were just asking if they were doing PrEP. Was there any discussion of or anything on the survey about future injectable delivery?
No, no, in the interest of keeping, because it was so big, so we just try, we had to limit the number of questions.
Right. And then Julie has had a lot to say. Julie, I don't know if you want to unmute yourself. I think this is great. I'm happy to read for you if you're not in a place where you can.
If you can hear me. I'm on my
Yeah,
phone.
we
So.
can.
Can you hear me? Oh, okay. Sorry, I didn't know how to do that since I was on my phone. But no, this is really interesting to me because I used to teach at Western and I tried to teach students about, the new laws about pharmacy enabled PrEP. But from what I've heard from like a lot of the community leaders is most pharmacists, there's not going to be uptake because, again, if they're providing the service and they're taking 30 minutes, an hour away from their other workflow and not getting compensated, most pharmacies are not going to allow that to happen. I think there are ways that pharmacies can bill for that. I just don't know what the infrastructure is. And again, if most pharmacies have resources on that, and it kind of goes to the push to getting pharmacist provider status, but there's been a lot of lag on that. So I think if that can happen, again, I don't know if a lot of chains will take up on it because this isn't taught well in schools and a lot of community pharmacies are still going to probably not want to, but I think there will be more that are interested if they can get compensated.
Thanks, Julie. Just came in at 9 o'clock. I know we have to get off, but Aaron said, I think a lot of the barriers, EHR build, access to the labs, billing would be minimal at UCSD. Are there thoughts to grow access within UCSD pharmacies specifically for PrEP and PEP? I mean, that's sort of what we're doing, Aaron. I guess you mean like walk into a UCSD pharmacy and get it, but that's what Christian essentially does. He's a pharmacist who prescribes PrEP for patients. I don't know if you mean something sort of outside of that, like the other. I'm assuming you mean someone walking into a UCSD pharmacy. I don't even know where they all exist, but somewhere else, and just saying, I want PrEP and what that looks like. Yeah.
Yeah, I think the issue goes back to what Julie was saying. It's the same thing at UCSD as time and who is gonna take time to get away from the workflow, which is already stretched, to then enroll patients or prescribe or do a consultation. It's the same issue.
And if they're walking into MOS, right, they can just walk upstairs is the idea. That's just a few floor
that one,
different.
yes, but I think Erin's thinking more, outside the box. If somebody's like in this county, Escondido, or whatever.
Well, he actually wrote, I'm
Alvarado,
thinking of someone walking into MOS. So that one's easy, but I do
that one
agree.
is easy. They would just message one about it. But.
Yeah. Anyway, sorry. All right, it's 9:02. Thank you so much.
Thanks, everyone.
Gabe.
Thank you for being here. Thank you for being
and
here.
we look forward to seeing everyone next week. Thanks for joining. Bye.